I wanted to finish up on the ACF policy statements that came out about use of CTs in the suspected appendicitis. They came out in October 2009. When they do these policy statements, it's not a very big focus in terms of here's everything that we say about CTs and appendicitis. They focus on very, very narrow questions, 2 or 3 narrow questions, and come up with an answer, what they say is an answer. So let me just read one of these to you. This is about contrast in adults in appendicitis. The addition of IV and oral contrast may increase the sensitivity of the CT scan for the diagnosis of appendicitis. Come on. The addition of an IV and oral may increase. My friend Jerry Hoffman says, whenever you say the word may, you can equally substitute the phrase may not. You know, may not. So that's the college at work helping to clean this stuff up for us. With regards to kids and children, use ultrasound to confirm acute appendicitis, but not to definitely exclude acute appendicitis. So that's the idea where ultrasound first. That sounds pretty good. That's considered a level B recommendation. Level C, which is kind of like just basically opinion. Consider using ultrasound as the initial imaging modality. In cases in which the diagnosis remains uncertain after ultrasound, CT may be performed. So they're endorsing the ultrasound first technique, and I think that the literature on that is compelling, why they're taking such a kind of a soft position on it. We need to basically do that more, and we need to increase the number of ultrasounds that we're doing, not decreasing them. We're going to pick up with use of MR or ultrasounds in ruling out appendicitis in pregnant people. The first paper kind of looks at, does an overview, CT, MR, pregnancy, and they say CT is not a teratogenic risk. It's not going to, you do a CT, you're not going to have 4 fingers and your kid. It is a carcinogenic risk, and obviously it's a substantial one considering how long this opportunity is for mutation into cancer, but it's not a teratogenic risk, and therefore it is not considered warrant termination of pregnancies. They talk about doing MRs, they ought to be avoided in the first trimester. Why? We're not really sure what putting these neutrons and positrons in the same direction is going to do to and obviously there's no studies on this, so they said try not to do it in the first trimester when organs are being formed. They suggest always, if you're going to do an MR in a pregnant person, that it be preceded by an ultrasound to see if you can make the diagnosis of appendicitis, but that as that pregnancy progresses, the ultrasounds are going to be more and more and more likely to be indeterminate because you can't do the graded compression that you need to do to see appendix. And so it's a problem. After about 30 weeks or so, they basically say, it's not going to help you. That doesn't mean you can't do it, but the likelihood of positive findings on ultrasound are going to be very, very small. 29 to 31 reflects the fact that ultrasound, although a reasonable first test, becomes more and more unhelpful as time goes on. Like 29, it wasn't, they're talking about, all right, now since ultrasound's not going to be helpful, it's going to throw in an MRI for a pregnant woman. MRI was helpful in making a diagnosis of appendicitis or other pathology, but it certainly wasn't as good as we're used to in non-pregnant people with getting a CT. That's number 29. However, 30 is a much more positive paper. It makes it clear how unhelpful ultrasound is as the pregnancy goes on. And in this study, MRI was particularly good. Ultrasound demonstrated in this study appendicitis in 2 of the 4 cases that had it, 2 of the 4, but could not visualize the appendix in 46 cases. MRI, on the other hand, picked up all 4 cases of appendicitis and was negative in 44 and inconclusive in only 3. That is approaching the numbers we're used to for CT and appendicitis. The authors concluded that MRI was reliable in excluding appendicitis in pregnancy. This is one of probably the better studies in terms of how well it was. Oral contrast was used to enhance imaging in this study. Sometimes they even use just water to enhance these things. A normal MRI is highly likely to be consistent with the absence of appendicitis. Okay. There's a similar study, 33 pregnant women. Again, ultrasound was indeterminate in 29 of 33. So, doesn't help. MRI was true positive in all 4 cases of appendicitis. MRI was true negative in 13 and indeterminate in 16, which is more likely to be the case for you at your hospital. A lot more of these cases are going to be indeterminate than there was in paper number 30, which was exceptionally good results. The largest study of MRI in pregnancy is 32. It's a new study, came out in last year, 118 pregnant women. They noted the acquisition time for MRI in pregnancy was quick, 34 minutes, not bad. The mean gestational age in the study was 21 weeks, so that's not very far along. That's the mean. That means, you know, at 20 weeks you can feel the uterus at the umbilicus, isn't that where it is about? So it's not like these women were huge by any stretch of the imagination. The sensitivity for MRI picking up appendicitis was 90%. Well, if you remember from yesterday, what was the sensitivity of CT for picking up appendicitis? It ranged between 90 and 100. The average is probably in the neighborhood of 94, 93, but it was as low as 90. So this is pretty much the same as some of the CT studies. 90% picked it up. And when they said it was appendicitis, it was. Specificity, excellent, 98%. So this is pretty decent. Have any of you had any experience doing MRI in pregnant women for appendicitis? And anything help? Yes, no? You don't really have a lot of choices, to tell you the truth. Ultrasound is not going to be too helpful. Some other diagnoses to consider: epiploic appendicitis. This is that little thing that's like the tip of your finger, little fat jobber there, all along the colon, torsions, or ischemic process. You get a dying venous thrombosis in that thing. It becomes inflamed, causes pain, mechanical, rather sudden onset, very sharply localized kind of thing, generally not associated with any abnormal lab tests, generally not associated with other symptoms like nausea or vomiting, but it is considered appendicitis mimic. This diagnosis can be picked up on CT. Anybody ever make this diagnosis? So when you're familiar with it, it becomes more and more common. It's interesting that paper number 34 here contrasts some of these other papers about the clinical presentation of this mechanical event where this little thing twists. In that it says there was a gradual onset in 3/4 of the cases. Well, that's kind of contrary to the other papers. And they also said anorexia, nausea, and vomiting, 20 to 35%, which goes against the other papers that said this is a mechanical event. You have pain, but that's about it. It comes on suddenly. 35 and 36 are reviews of that topic. Mesenteric ischemia is another diagnosis that would be associated with taking a CAT scan. And the connection here is the first paper is on 2009 papers about atrial fibrillation and mesenteric ischemia. There's this whole subset of people who are prone to mesenteric ischemia, but certainly atrial fibrillation. So if you have abdominal pain, traditionally disproportionately painful with clinical signs that don't go along with that, they're supposed to consider this. The first paper here, number 37, unenhanced scans were done in 30, followed by enhanced scans, IV, in 26. I don't know why you would do an unenhanced scan when you're looking for a vascular problem here. So this would be a case where I would think you just shoot with IV contrast, although most of these people are going to be older, and there's the issue of contrast-induced nephropathy. Maybe that was some of the reasons that they were kind of a little gingerly about giving IV contrast, but the majority of it got it, but on a second scan, so it was kind of strange. Pain out of proportion to physical findings, and then they talk about some of the other things that go along with this diagnosis of mesenteric ischemia. Elevated lactate, metabolic acidosis, that's the same thing. And by the time you've got elevated lactate or metabolic acidosis or phosphate elevations, you're talking about dying or dead bowel. So it's certainly not an early finding, but they're basically said, consider this diagnosis, atrial fibrillation. Those are the people who have had prior abdominal angina or mesenteric ischemia, severe vascular disease spread around the body. That's the time to consider this diagnosis. Israeli study, 92 people, IV contrast only, as you would anticipate ought to be used. 18 of the CTs were consistent with mesenteric ischemia of the 92 patients. 16 were true positive. 2 are false positive, so these are never going to be 100%, but that's really still pretty good. Of the negatives, 74 negatives, 72 were true negatives, and 2 false positives. So surprisingly good, surprisingly good. IV contrast, it's amazing the number of Israeli studies that looks at advanced imaging techniques. Splenic infarction is another entity. They talk about, again, atrial fibrillation, throwing a clot, blocking up your spleen, and in association with sickling as well. The mean age of these patients that is outlined here, these papers 39 and 40, surprisingly old, 54. They're talking about left upper quadrant pain or flank pain. Why would an ischemic spleen cause pain? Well, this does. In fact, 1 out of 10 of them, the spleen became enlarged. Predisposers, atrial fibrillation, prior thromboembolism, use of oral contraceptives, previous cardiac valvulars. Basically, anything's going to shower something down into the spleen that will, on the arterial side, that's going to cause it to become ischemic and painful. 40 is a paper on the things that sicklers can have in their belly. The issue here is there's 2 kinds of pain in the sickle pain, the musculoskeletal or the back pain, the extremity pain. It's ischemic pain. It is ischemic pain, which is hard to localize, dull, boring, becoming intense. And the pain in the abdomen, which is the second most kind of split crisis associated with pain crisis, is repetitive pain that's always the same without peritoneal findings. And the person says, yeah, it's the same as it was last time. Yes, it was the same as it was last time. It's the typical pain. The fact is that in these cases, they're talking about unusual abdominal pain in sicklers, or maybe accompanied with a fever that makes you think more that there may be something going on in these cases. And so there's a whole litany of things that have been found in this 30 sickler study, and number 40, all of them got IV or oral contrast in most, I don't know why, IV contrast in the rest. So there's a long litany. Diverticulitis is in that list. 41 is 120 suspected left-sided colon lesions. They point out that 65% of people over the age of 65 will have diverticuli, and about up to a quarter of them will become symptomatic. Well, in this study of left lower quadrant pain, the diagnosis was diverticulosis in a half of them. CT was falsely negative 2 and falsely positive in 1. That's really pretty good. CT scanning also diagnosed a bunch of other things when it wasn't diverticulitis. It concludes that CT imaging is the imaging of choice for diverticulitis. They're talking about, and what kind of contrast. In this study of 41, they used rectal and IV contrast. Rectal contrast, you might be a little gingerly there, because some of these have obviously perforated to a certain degree. Ureteral colic, there's 2 sets of papers here. One of them is, when can you use contrast in a patient who's getting a CAT scan for their kidneys? Because there's a subset of cases where you've done a plain scan and you're still concerned, and you might have had some hematuria and flank pain. The first scan, unenhanced, is normal. Then they say, well, there's some justification for doing scans with contrast in that setting. They're picking up a whole bunch of weird stuff like renal infarctions, renal vein thrombosis, acute pyelonephritis, urinomas, hematomas, renal cell cancers, those kinds of things. Certainly, so there is some justification. Plain one is normal. I'm really concerned. Hematuria maybe. So this would be an indication. They also talk about all of these people who have recurrent stones, and can you keep on CTing them, CTing them? There's 2 papers there that I think are pretty remarkable. Number 45 and 46. 45 reiterates that CT of the abdomen is associated with lifetime risk of cancer of 1 in 1,000. 1 in 1,000. You'll see some papers that say 1 in 2,000. Well, the fact of the matter is that you have to qualify these by saying how old is the patient you're talking about. In this study, in this statement, they're talking about if you're 20 years old and you get an abdominal CT, the likelihood of you getting cancer is 1 in 1,000. Other people say 1 in 2,000. Well, that's not a 20-year-old. What if it's a 40-year-old? If you're a 40-year-old or 35-year-old, then the risk goes down of you getting cancer over time. So there's 3 variables that determine your risk of cancer. How much juice you get and how old you are the 2 dominant ones. So in this study number 45, this is 356 people who have recurrent kidney stones. Half had at least 2 CTs, 10% had 5 CTs. It's not all that bad, really, but look at this. 5 of them, 5 had at least 9 CTs. A 28-year-old had 14 CTs, a 42-year-old had 22 CTs, and a 53-year-old had 25 CTs. The next study from Yale says, what was the radiation consequences of getting a bunch of CTs? This is a 6-year study looking at 4,500 patients with suspected renal colic. They got 5,500 CTs. 60% of them were females. 1 in 40 was a kid. 1 in 40. I can't recall doing a CT for a kid's kidney stone. But anyway, they did pretty well here. Only 19 had 6 or more. One patient had 18. But then they said, what was the radiation consequences of these multiple CTs? CT radiation dose per CT, they said, was 8.5 millisieverts, which is the number that people keep on coming. It's somewhere in the neighborhood of 8 to 10. So they said it's averaged out 8.5. Those with 3 or more CTs, total dosage ranged between 20 and 154 millisieverts. 154 millisieverts is huge. To put that in perspective, the survivors from the Japanese A-bombs, their average dose ranged between 5 and 200, and a lot of those people obviously got cancer. So this was right in the A-bomb range, the high A-bomb range for these people who had 3 or more CTs for their recurrent stones. They advise using low-dose CT. Remember yesterday we talked about you can turn the juice down, and instead of doing an 8.5 millisievert CT, you can do a 4 millisievert CT. The question will be, is the visualization going to be quite as good? The papers yesterday said it was surprisingly similar. So that's one of the strategies in these multiple, when these doing recurrences. The other strategy is plain x-rays with ultrasound. So once you made the diagnosis 2 or 3 times, enough. That's it, it's another stone kind of thing. And so the vast majority of these multiple CTs are being ordered by emergency physicians over and over and over again, unaware of the huge number that is ultimately being accumulated. The next question, are the radiation doses associated with abdominal CT of concern? That the 2 greatest populations increasing in CTs are kids and these body CTs for screening. The kid thing is about faster CTs where you don't have to sedate kids. Well, it used to be a problem. You had to sedate them. And I said, I don't want to do that. You know, well, Johnny really doesn't need it. Now that you can do them really quick, in they go, in, out. So they're disproportionately going up in the kids who are just the most vulnerable of the population. In terms of the numbers, 15 years ago we did 20 million CTs. Currently we're in the neighborhood of 70 million CTs. 70 million into a population of 300 million. So that's 1 in 4 people per year kind of thing. The Japanese do 2 to 3 times as many CTs as we do. They love them over there. They're lighting them up. The literature has a recurring theme in this. Doctors underappreciate the radiation risk, and that's why with the FDA yesterday, the day before, came out with, we're going to focus on this. We're going to try to educate doctors and patients about the risks that are associated with this, the overutilization of these tests, those kinds of things. Many scans are unnecessary. I'll show you a couple of papers that try to tell you how many are. Having one CT predicts having another, and we'll show you a couple more papers that will reinforce that. Patients are not aware of the risks. Knowledge of the risk is not shared with patients, and there's papers in there that make it really clear that the patients are pretty clueless. Some consider it an ethical imperative to obtain informed consent in elective scans. Well, you know, some of the sliding slope between elective and emergent scans, not every one of the scans we do in the emergency department is an emergent scan, just because it happens to be done there. And so the issue becomes this idea of shared decision-making. And I'll show you some really big contrast between some places where we are disproportionately worried about stuff that we shouldn't be, and then this area where we are under-concerned, where we probably ought to be. 48 is a paper looking at unjustified scans using criteria developed by the European Commission, and they concluded in a Finnish study of 200 scans that 30% of them were unwarranted. Now, when you look at what they say you should have been able to do, a lot of them they would have swapped out an MRI for. Lumbar spine, as an example, 23 of 30 lumbar spine CTs were felt to be unjustified using this standard. They said 20 studies could have been replaced by MRIs. It's kind of it's the right study for looking at nerves. And they talked about head CTs. 18 of 50 head CTs were unjustified. MRIs would have been preferred. All of the CTs in the setting of trauma they thought were justified. And 49 gets into the ethical issue regarding parents, patients and recommends that parents keep track of imaging studies just like they do regarding immunizations. 50 focuses on the lack of information regarding indications, benefits, and risks based on a survey of 768 adults waiting for an outpatient CT. They point out that the future risk of cancer is somewhere between 1.5% and 2% of all future cancers will be caused by CTs. 1.5% to 2%. 1 in 50, 1 in 65 or so cancers will be caused by CTs. And that's assuming that everything stays the same, but the rate of increase of this is certainly something to take into consideration. 51 is, I think, one of the most powerful studies here. It reviewed the course of 130 people who had 3 ER visits within 1 year, and one of those ER visits was associated with a CAT scan. And then they followed them for 7.5 years, 130 people. The average numbers of CTs that these people had over the 7.5 years was 13.5. It's inconceivable. 13.5 was the average. So that this subgroup of people, you went to the ER a lot, 3 times in 1 year. You had, during one of those visits, you had a CT. And you took all of those comers here, 130 of them, and they averaged 13 CTs over the next 7.5 years. Unbelievably large number. The mean, the maximum was 70 CTs in 7 years, 7.5 years. That's 10 a year. It's like your monthly CT time to you have an appointment, you know. The mean cumulative radiation was 122 millisieverts, the mean. That's way into the number for the Hiroshima people, way up there. And the guy who got the 70 CTs, he had 579 millisieverts, off the chart. His risk of getting cancer from those CTs was 1 in 17. The average risk of cancer for these 130 people who got the 13.4 CTs on average was 1 in 82, 1 in 82. And it was everybody, you know, nobody knew that somebody had had one before, how many you had before. And I think a lot of this is ER-based. 53 attempts to put the radiation risk associated with imaging studies into some perspective, because those people who challenge this say, you know, the data on this is really not really solid. You cannot say with any degree of certainty that 1 in 1,000 people are going to get a cancer and die from it from an abdominal CT who is 20 years old. So this is all extrapolation and speculation, and you know, some people say it's more valid than not, other people are challenging it. But everybody agrees that there is a risk to medical radiation, and by far when people talk about medical radiation, they're talking about CTs. One abdominal CT is 500 chest x-rays, and so to put that in perspective, it's all about CTs, and a few cardiac studies that we'll talk about in a second. But so there is this issue of informed consent. Particularly in areas where it's kind of equivocal. This author, number 53, says, physicians have an ethical responsibility to convey this risk to patients and parents in a setting of higher radiation exposures to allow for shared decision making. The fact of the matter is that what doctors do is they don't say a word, or they underestimate the risk for patients, as in, you know, no big deal, or the extreme is full disclosure. How many of you have any kind of formalized disclosure of CT risks where you are? Really, one?
I do. I explain that, you know, like a belly CT is 250 chest x-rays worth of radiation.
Well, you know.
I've met young people that come to our ER, and you know, there's some of my colleagues that are very, you know, guilty of this. And one woman specifically, I said, well, have you had a CT before? She says, no. I go back and look in the records after I've ordered the CT. 16 CTs.
A woman said she didn't have any CTs, and
Never
she's denied ever having a CT and had 16 of them.
It's like, this is what you're dealing with.
So, but any of you have like a formal piece of paper that says and sign here kind of thing if you agree to accept the risk? Anybody? No. But do you have something similar when you get a contrast IVP? Used to have that. A lot of people used to have consents for those, telling you about the risk of a contrast reaction. Do you get red when you eat lobsters, strawberries, tomatoes, those kinds of things? And that was quite formalized for contrast reactions. These papers say the risk of having a serious contrast reaction is 1 in 400,000. 1 in 400,000. And we used to sign papers for that. And we're not signing anything or at least formally telling people about some of these risks.
Rick, could I, so you're saying that one CAT scan carries that 1 in 1,000 to 1 in 2,000?
That's what people have asserted in a 20-year-old.
What's the baseline if you don't have a CAT scan?
I don't know. I don't know. This is basically in addition to what the baseline was, which is probably pretty small. So it would be nice to say, well, 1 in 1,000, most people can understand. 1 in 1,000 people will get, and the question is, do you want to assume that risk? In all kinds of other areas that we've looked at, patients are surprisingly conservative about assuming risk. There was a great study that looked at patients wanting to be told about the side effects of medications. So you go into the PDR, and there's a whole list of these things which we never really tell anybody about. All of these are associations. We don't know that they're causality. But when the patients were surveyed, they said, yes, I want to know about the risks associated with these medications, much more so than you would have ever anticipated. Patients are not particularly willing to take risks. And so they may be particularly conservative about this. In fact, there was a paper that who talked about the TPA? Was it Neil? Did you do TPA? Somebody talked about TPA here, and there was a study where they asked people whether they would be willing to assume the risks of a bad outcome with TPA. And when they were asked this, they were not willing to assume it. Even 2% risk of mortality, they were not willing to assume. That was too high for them. So, and every paper that I've looked at that has looked at people's perception of willingness to accept the risk says they're willing to accept less than you are. Than you are. That's why there's this idea of shared decision making comes up in this thing. You can't just tell them, this is 500 chest x-rays. Most people could understand that kind of thing, 500 chest x-rays. And one of the most discouraging things about CTs is the literature that we have that talks about the study where they did CTs of kids' heads and their intellectual performance. Because one thing, cancer is one thing. It's you either have it or you don't. But this study looked at radiation of kids' heads who had CAT scans, and they compared it to radiation and this was in a closed population, I think it was Sweden, where kids had been irradiated for hemangiomas of the face, and they followed them over a period of time, and they determined that the radiation that those kids had for these lesions was the same radiation that you would get from doing a CAT scan of a kid's head. And they looked at their intellectual performance in terms of everybody in Sweden takes a test when you finish high school. The kids that had the radiation did less well than those kids who had not had a radiation. At the end of high school, they had another test to get into the military. And the kids who had radiation scored worse than the kids who had not had radiation. So one of the things that is concerned here is whether you're going to potentially be affecting a child's intellectual performance, which is not a black or white kind of thing, but which is on a sliding slope here kind of thing. And can you imagine, how parents would feel if you knew that this kid, his intellectual performance has potential, and the study that we have it in the abstract database, the potential for that appears to be real. And even if it's so-so, it is much more frightening, I think, than 1 in 1,000 is going to get cancer and die from it. Because parents would feel absolutely terrible. And so, if you get familiar with that paper, you can use that as part of this, Mom, I don't think we really need to do it. We can bring them back. And I am concerned about not only this potential cancer risk, but I'm concerned about any intellectual performance issues. Now, if you send those patients out and go to the family doctor, they might say, what, are you serious? Light them up. But this whole literature is, we're not adequately aware of the radiation consequences of what we're doing here. 55 is the one that says, contrast reactions, 1 in 400,000. We will make a big deal of that, but we're not making a similar deal about these risks associated with radiation. And then lastly is 56, which is another Israeli paper looking at what were the consequences of radiating a bunch of kids in 1 year. They looked at every kid who was irradiated in Israel for 1 year. It was 17,686 CTs were done. And they said, how many cancers are we going to get from those? Because kids, obviously more susceptible, but it's not only in terms of the delivered radiation, it's the absorbed radiation, and this gets a little bit complicated, but this paper says the effective radiation dose is 50% higher than the dose delivered to adults. So delivered dose and effective dose, there is this nuance here. They basically say that it is more when the kid gets it. They estimated of the 17,000 scans that they did, one death would result for every 1,863 scans. One death from every 1,863 scans. Well, most people are certainly going to be willing to take those odds, but remember, when you're doing 70 million CAT scans, start multiplying that about how many people are going to die from those. 1 in 1,000 for 70 million, 70 million CAT scans. The number gets to be a real number. The last thing is paper number 57, which gives a graphic depiction of the risk. So I think it's in your book there, this thing here. Now here's a problem. This basically says that along the bottom, along the horizontal axis is the equivalence in chest x-rays. So the 1,000 is 1,000 chest x-rays, 500 chest x-rays. Then you go up the line, it says an abdominal CT, you go up to 500, is about, now they say 1 in 2,000 people will die. 1 in 2,000. But they don't, what this graph doesn't have is how old are these people? So you'll see this conflicting number, 1 in 2,000, 1 in 1,000. Think of it as when the younger people, a 20-year-old, it'll be 1 in 1,000. So you can get, a thallium scale is off the chart. A thallium scan. So it gives you some idea of radiation. And on the left, it is lifetime additional risk of cancer. Goes up from 1 in 20,000 to 1 in 2,000 to 1 in 1,000. So there is a paper there that I didn't mention that has a lot of references that you can get on the internet regarding things that can be used to help people understand the laymen understand the risk versus benefit ratios. I don't know whether anybody's going to change their practice, to tell you the truth, because we have a computer program. Come on up, Neil. We have a computer program that measures every blood test, every imaging study done by every doctor in our department. And the difference between the low utilizers and the high utilizers is 2.5 times. 2.5 times. No business would tolerate that variability in practice. They call it the art of medicine. 2.5 times variability. This is looking at 24,000 patients seen by the doctor, so that they can't say, well, I had a bad week. This is 1 year's worth of behavior, and every year it's the same thing. We have a huge variability. And this is like 12 doctors. Can you imagine what the variability must be, just if we took the doctor's practice in this room? It would be huge.